Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. The topic for today will be female incontinence, and I welcome Dr. Alyssa Gracely. You are a urologist with Chesapeake Urology here in Salisbury, and you're fairly new to the area, but we're excited to have you. So welcome to the program.
Thank you so much.
And we are ready for you to share your expertise on the topic of incontinence. And we're going to focus mostly on women.
Correct.
And focus on stress and urge incontinence, but there's some other types. So let's start with just an overview of incontinence and the types of incontinence that you see.
That sounds very good. So there are, as you said, two main types of urinary incontinence, but I want to just clarify that there is this third tricky type that we want to make sure we rule out before we talk about the two main types, and that's overflow incontinence. And the reason it's important to rule that out is because that comes as a result of not emptying the bladder well. So the treatment for that is to get us emptying our bladder better, because that's sort of your bladder fills up and just can't hold anymore and spills over. And so that's the only type of incontinence that is a safety concern because it comes from not emptying. And so the first step in any patient who comes to me with incontinence is to make sure that they're emptying their bladder well. And we usually do that with a little bladder scan. And as long as they are emptying their bladder well, we move on to the more common types.
Maybe explain quickly what a bladder scan is. It's a pretty nifty tool.
It is. It's just a simple ultrasound, so a little cool gel on the belly and then a little, very gentle probe that monitors how much urine you have in your bladder by way of an ultrasound. So incredibly non-invasive.
Very good. But anyway, just incontinence in general, I think the most common type most women may mention or many experience is the stress incontinence. So maybe let's start with that one, and then you're going to talk a lot more about urge.
Absolutely. So stress incontinence is the one that most women, I think, are familiar with, and that's the leakage of urine or the loss of urine that comes from physical activity. So think leakage of urine with laughing, coughing, sneezing, lifting things, playing tennis, anything that really increases our belly pressure and causes that sort of involuntary loss of urine would qualify as stress incontinence. And that's a result of weakening of the pelvic floor muscles or the urethra, often as a result of childbirth and just part of the aging process as well.
So how is that particularly diagnosed if someone comes to the office? I mean, I think a lot of women know that can happen and it sometimes will go away, and you hear about the Kegel exercises and so forth, but if someone comes to your office, you'll do a little workup to determine the stress incontinence, or of course to rule out the other one.
Absolutely, and it is important to make sure we're dealing with the appropriate type of incontinence as the treatments differ. So we have a conversation. Most of the diagnosis comes based on that conversation, and usually women are able to really delineate when they experience the leakage. I of course like to do an exam with a full bladder as well to see if we can demonstrate it with some of those activities, coughing, sneezing, bearing down. But if we can't demonstrate it in the clinic with an exam, because a lot of it is very activity specific, it doesn't mean that I don't believe you.
Sure.
We can take the history as truth as well.
So once you confirm this, then what are some of the treatments that are recommended for stress incontinence?
And so that's my favorite part about treating incontinence, is that there are so many treatment options. Stress incontinence is a quality of life issue. Incredibly important that we treat quality of life issues, but it's not a safety issue. So for me, it's really important that we find the treatment that matches the sort of goals of the patient, which includes talking about the benefits as well as the risks. So we can start incredibly simple. The very simple treatment options for stress incontinence are the Kegel activities, exercises, working on weight loss, and then if they're interested, referral to a pelvic floor physical therapist specialist who can do an evaluation of the pelvic floor muscles and work on a little bit more specific exercises beyond just the Kegels.
I've never heard of a pelvic floor physical therapist.
They're wonderful.
Really?
They're physical therapists.
Is that a fairly new specialty?
I don't know how long it's been around. Because I specialize in women's health, it's been something that I've had access to as a resource for at least the last 8 years. Not entirely sure how long they've been around, but they are a lovely resource and really do wonders in educating women on pelvic floor muscles and how to sort of isolate and use those muscles appropriately.
Is the incidence of stress incontinence related to like how many babies you've had, or do some women still get it even if they just had 1 or 2 children? Or
that's an excellent question. Certainly the risk can increase with subsequent births, but a woman who's had only 1 can have stress incontinence, and a woman who's had 5 could potentially have no stress incontinence. So just because you've had multiple babies doesn't mean you're for sure going to have leakage of urine, and just because you've only had 1 doesn't mean you're guaranteed not to.
And are Kegel exercises a good idea anyway for most women that reach middle adulthood?
Absolutely. They are always a wonderful opportunity to strengthen the pelvic floor muscles. They can decrease risk of incontinence. They can decrease risk of pelvic floor prolapse, and just improve overall pelvic health.
Very good. Okay, so no real medications there, just more about just strengthening.
Yes. Unfortunately for stress incontinence, because it is a sort of structural issue, there are no medications to fix that. We start conservatively, weight loss, exercises, physical therapy, and if those don't work or they don't match the treatment goals of the patient or they've tried them at home already, then we can move to something like a pessary. So those are vaginal inserts that have, they're flexible and they have a support that functions to act as that extra support that's been lost for the urethra. The beauty of the pessaries is that they are non-surgical. They can be removed, especially if you're only having situational incontinence. So a really great option for a woman who, say, only leaks when she plays tennis or, goes for a run. And then she can use that just for those activities and then remove it. The downside is that it is not a cure. Once you remove the pessary, the incontinence comes back.
Well, the good news is for any of these is it seems like we've come a long way with pads or inserts that are so sleek now you can hardly tell if you should have to resort to that or feel more comfortable, correct?
Absolutely. And pads are always, a reasonable conservative management option. We don't ever have to treat stress incontinence. It's all based on how much it bothers the woman. And if it is bothersome, we have many options, but never ever would I force a woman to have treatment for this because it really is all about their quality of life.
I did think you wanted to talk about some office procedures that can be done to address stress incontinence if the more conservative treatments do not work, correct?
Absolutely. So there are a couple of options available when our conservative options fail. And those are an office-based procedure that's done with some local medication or a more surgical procedure done under anesthesia. So the office-based procedure is called urethral bulking, and historically there were a lot of different bulking agents available. We have a newer agent now that's a little bit more friendly, a little bit more successful, and it's a water-based gel. So there's really no inflammation to the tissue, and it stays in the tissue and doesn't have any reaction. So it's a lovely option.
So where is that injected exactly? I'm just curious.
That's
Without
a great
getting
question.
Too technical.
Yeah, so it's injected just under the wall of the urethra. So after we put some numbing medicine at the site we're working on, we pass a small camera through the urethra, which is the channel that women pee out of. And then using a small needle, after we're numb, we inject small cushions under the urethra to help re-support the urethra. It only takes about 3 to 5 minutes. There's 0 downtime. You can go back to all your activities. It's a really lovely treatment option, and 8 out of 10 women don't seek other treatment afterwards.
That takes care of it.
It does, yes.
Very good. And I know I've heard of the surgical sling procedure, so what's involved with that?
So that's the procedure that most women are probably familiar with for stress incontinence, and it does work very well. It is the most invasive procedure, but it has the highest success rate. It is done with the woman asleep under anesthesia, and we make an incision at the urethra and pass a ribbon of mesh generally, but we can use the patient's own tough connective tissue if they want instead of the mesh to support the urethra. It acts as a hammock under the urethra to help resolve the stress stress incontinence. And that's successful over 9 out of 10 times.
Very good. It's really wonderful now, all the different options to help with this, because incontinence, it's such a worrisome concern for women and still a bit stigmatized. I mean, women are so nervous about seeking treatment for it, and there's so many different treatments now available compared to years ago.
That is what I see most when I talk to women. In fact, many don't even mention it because they think it's what they have to deal with and it's just the part of being a woman. And while it's true that it's very common, it's not something that we have to live with. There are lots of treatment options that can match your quality of life. So there's a fit for most people.
And they're effective, you say?
Absolutely.
Very good. So let's move on to urge incontinence, because that's a bit of a different animal. So what is that? And of course, what are some of the symptoms or how it's determined to be urge incontinence specifically?
You're absolutely right. It is a completely different animal from stress incontinence, but it can be present as well as stress incontinence in the same person. It's due to the bladder squeezing more than we want it to. So the bladder is a muscle, and sometimes it becomes, just like you said, overactive. So we want it to relax when the bladder is filling, and that's what it's supposed to do. But occasionally it'll start to squeeze instead of relax, and that gets you that sudden urge of, oh my goodness, I need to pee. So I'm sure many women have seen the commercials of that gotta go,
Key in the door.
Exactly,
yeah.
looking for the bathroom, and that's exactly what we're talking about. So urge incontinence is that leakage of urine when you get a strong desire to pee and can't make it in time.
So a woman will be experiencing that and see you. So is that diagnosed with just history or exam or anything special that's done to determine that's the cause?
So similarly to stress incontinence, most of this is done with our conversations. So we get an idea of when the leakage is occurring based on, the daily activities. Sometimes if it's hard to sort of pinpoint what that is, we'll have the patient complete a diary. So I send them with a device to collect urine and put it in their toilet, and then they write down when they're drinking fluids and how much they drink, and when they pee and how much they pee. And I ask them to pay a special attention to if they do get those strong desires and to document that as well. And usually that's enough that we can get a really good picture of the type of leakage we're dealing with.
For how long do they do the diary?
2 to 3 days.
Oh, okay, that's all?
Yeah, that's enough to give us a really good picture of their daily habits.
And so what's the usual treatment for this type of incontinence?
So just like stress incontinence, we have a lot of options because it is also a quality of life problem. So the treatment should match the patient's quality of life goals. Similarly to the stress incontinence, we start conservatively. It's important to know that there are some things that can irritate the bladder and make these symptoms worse, and those are caffeine and alcohol and artificial sweeteners. So often we talk about minimizing those particular irritants as a first starting line. And of course, that's not the only thing we do. We can also do exercises and use a pelvic floor physical therapist to help teach exercises for relaxation and deferring that urge. So they're an excellent resource. When those fail, we try medications. So this is the type of leakage where a medicine can help.
So what medicines are available? I know there's a few different classes, and some of them have been around quite a while.
Absolutely. There are 2 classes of medicines, and one has been around for quite a long time. So the one that's been around for a very long time are called anticholinergics. What they do is to relax the bladder, and they do that well, but there are also those same receptors in other parts of the body, so they can cause some side effects such as dry mouth, dry eyes, and constipation. And we don't love them in older women because there can be some risk of association with dementia.
So what would be an example of those medications that are commonly used?
Some common medicines are oxybutynin, Detrol, Vesicare, Tolterodine. There's a lot of them.
Oh, really? Okay. And you said there's a newer class now that's actually being used more.
Yes, there is a newer class, and the reason we like this medicine a little more than the older ones, even though they work great, is that there are fewer side effects. So they work on a receptor that's more present on the bladder and not really present anywhere else in the body to relax the bladder. They're called beta-3 agonists, and those two medicines that are available now at least are Myrbetriq and Gemtesa.
And so you're saying they don't have many side effects, they're much safer in that regard and just as effective?
Correct. They are just as effective, and they don't have as many side effects as the other medications. There's potentially a slight risk of a very small increase in blood pressure, but that it generally hasn't been shown to be clinically significant.
Well, very good. But you're saying, we were chatting before the program, you were saying there are some other treatments too. Is there a chance these medicines don't work and you move on to another level of treatment?
Yes, so there is a chance the medicines don't work. They do have about a 60 to 70% efficacy in improving symptoms by about half. And so people who have very severe urge incontinence, that still might not be enough to get their treatment goals reached. Or they might have bothersome side effects. Or they might just not want to take a daily medication, and that's okay too. So when any of those things are the case, we have 3 what we would call third-line options or procedural-based treatments. The most low risk of those is something called peripheral tibial nerve stimulation. And that's just an office-based procedure that involves placing a very small needle, kind of like an acupuncture needle, in a nerve that runs along the back of the ankle to the pelvic nerve complex that also involves bladder control. We stimulate that nerve for about 20 minutes once a week for 12 weeks in the office, and generally see about a 60% improvement in symptoms. The downside to that one is that it's a little time intensive, so you've got to commit to making a visit once a week for 12 weeks. But on the bright side, there's very little to no risk with it. The next treatment option is Botox injections into the bladder, which surprises a lot of women because they're familiar with Botox for wrinkles. Botox works by relaxing muscles, and the bladder is a muscle, and as like we talked about, the problem is that it's overactive. And so in the office, just with some numbing medicine in the bladder, we can inject that medicine into the bladder and have really lovely improvement in the overactive symptoms.
And is that staying power? Does it last for a while?
That's a really excellent question. It lasts anywhere from 3 to 12 months, but most people get 6 to 9 months out of it. So it's something that's done a couple times in the office a year for the patients, generally speaking.
And insurance covers that?
It generally does. Sometimes they request that we try the medicines first, but if they don't work or there's side effects, usually they have no problem moving on.
I mean, that's important to know.
Yes, it is, absolutely, because that is a very large part of healthcare. Any
surgeries for this, or usually the Botox or the stimulation work well?
So there is a surgery. It's called sacral neuromodulation, which is a fancy sort of way of saying that it's a procedure that helps regulate the nerves to the bladder. I kind of will liken it to a pacemaker for the bladder. It's a 2-step procedure done with some sleepy medicine, like for a colonoscopy, where we implant a pacemaker electrode by the sacral nerves that control the bladder. The beauty of this procedure is you get to sort of test it out before you commit to it. So we do a test phase for a couple of weeks, and we're looking for at least a 60% improvement in the symptoms before we put the permanent device in.
Now, what about the role of estrogen?
That's a really excellent question. The loss of estrogen with menopause can certainly bring on a lot of the symptoms of overactive bladder, both because the loss of estrogen can increase our risk of urinary tract infections, but it also in and of itself can cause some of those overactive bladder symptoms. So bringing back estrogen to the vaginal environment is a really excellent way to treat overactive bladder. We do that often by using vaginal estrogen, and we like vaginal estrogen over hormone replacement therapy with a pill or a patch for a couple of reasons. First of all, we really only want the effect in the vagina, and so the vaginal estrogen does a better job getting to those vaginal tissues. And second of all, we don't want the risks associated with estrogen replacement therapy or hormone replacement therapy. And using vaginal estrogen, it really is only absorbed in that local vaginal environment, and it's not absorbed in the bloodstream like a pill or a patch is. So you don't see the same risk of breast or endometrial cancer that you would with hormone replacement therapy using a pill or a patch.
So how is the estrogen applied?
There are multiple options. So a cream is an option. And it comes with a little suppository like you'd use for a yeast infection over the counter, or you can just use your finger. There are vaginal suppositories, which are tablets that go in the vagina. And then there are also rings that are impregnated with estrogen that you can leave in and don't have to apply quite as frequently. And all of them have the same benefit without any risk of the side effects from using a pill that you take by mouth or a patch.
Well, thank you so much for such a thorough description of these two types of incontinence that women can experience. And it's just really encouraging to know that there's so many treatment options, because I think for years women just suffered in silence, thinking there was nothing they could do.
And that's the biggest message I want to get across, is that just because this is a common problem for women doesn't mean it's something that we have to live with. There are treatment options for both of them, and we can find a treatment that matches the goals and the quality of life of the woman who's experiencing the leakage.
Well, again, thank you for coming on and talking about this very important topic.
Thank you for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.